one might argue that they are in fact two valencies of an ambivalent attachment style. So,
Whoa, nice. That's
yeah,
a nice insight.
there we go. Sometimes I'm not just a pretty face.
Well, hello and a warm welcome to episode 5 of the Dr. Sill podcast. In this episode, I had the pleasure of interviewing my colleague, Dr. Cameron Gill. Cameron is a wonderful psychiatry registrar who is in the final year of his training. And I remember starting off as a junior registrar, hearing him talk about attachment theory. And I was so happy to hear that he was open to doing an episode with me. And in this discussion, we covered attachment theory, the different types of attachment, and how they map and relate to different personality disorders. We discuss both research but also some clinical experiences and map the discussion and the content to our personal reflections. This was really one of those conversations where I just personally felt the time fly. It was so interesting and invigorating. And I remember looking at the recording clock thinking that maybe 30 minutes had passed and we were already an hour and a half into the recording. So let's get into it. But of course, before we begin, a quick disclaimer. Both Cameron and I are doing this podcast in our personal capacity. The views we're sharing here are not that of any medical college or any workplace. We are not representing anyone but ourselves. Any advice that is shared is general in nature and does not constitute personalized medical advice. Though I think it's wonderful when people comment and engage with my content, there is no patient doctor relationship formed by engaging in this content. Cam, thank you so much for joining me on a podcast.
Thank you
We
so much
kind
for
of,
having me.
yeah, my pleasure. We were talking about attachment and how that relates to lots of different things because humans
Hmm.
attach.
Yep.
So I was thinking a good place to start is to kind of address what is attachment. Like when psychiatrists and psychologists and people who work in mental health talk about attachment, to some people that might feel like psychobabble. you know, I'm not attached to
Exactly.
anyone. I mean, so
Yeah.
how do you think about attachment?
Yeah, that's a really interesting question. So, attachment is such a broad concept and it gets applied both in these really jargon heavy spaces, but then we also have ideas of it in our popular culture, and it's been really strongly incorporated into that therapy speak stuff, which, is a whole topic for another day. But fundamentally, attachment is a pattern of behaviors and beliefs that people have about themselves, about relationships, and about the world around them. And it's really been informed by those earliest experiences. Um, the ways that it informs beliefs about the self can stem from how we're treated, the way it informs our experience, beliefs about relationships and others, is like how those early relationships go, um, and the way it informs our beliefs about the universe is like, well, what is this universe? What does it mean to be alive, and what do we experience in it? So attachment is, to my view, it is the most fundamental aspect that of like understanding people.
Wow, you've added a whole new element to it. So what? So I really liked that you're talking about like a kind of intra personal attachment where you're how you relate to your personality to yourself,
Hmm.
whatever that is, and that's an
Yep.
interesting discussion. Your interpersonal attachment, but then that's a really interesting concept that's feeling so satisfying to hear. How you attach to meaning and the bigger existential questions of life and what we're doing,
Hmm.
and um, and I'm sure that there are healthy ways to attach and less healthy ways to attach, uh, and that different states of stress might bring out different ways of attaching.
Absolutely. So this is where it is really important that I establish that I have a very workmanlike, a very functional understanding of attachment theory. I am not an attachment scholar. And one of the advantages of that is there are definitely movements within attachment theory that posit a much stronger categorization that if you have one kind of attachment style or you belong in one category, that is the only category to which you belong and that informs everything. But reality is much more complex, and like clinically, what you see is that yeah, people move in and out of different modes. People, might usually have, to use the jargon term for the healthy attachment style, a secure attachment style, but then when they go through some enormously stressful experience. So, for example, the death of a loved one, people can sort of seem to shift into a different attachment style, one of the insecure attachment styles. So it's really important to reflect that absolutely these are ways of being, these are belief systems, and we can move between them, even though we tend to have a pattern of having one that is more predominant than the others.
So, why do humans attach? Why is it so important that we have relationships with others?
Really, really great question. One of the I suppose the way that I approach that is the reason humans attach is because we are mammals that are born at an incredibly underdeveloped stage. So, we're not like sea turtles where the egg gets buried in the sand and then am I allowed to swear in here? Can I,
Sure.
mum
I don't know, but go
yeah,
for it.
sure. Mum fucks off, and then we 2 months later crawl out of the sand, run the seagull gauntlet, and then we are expected to thrive on our own, right? That's how sea turtles do. We're also not like some other mammals, like giraffes. Giraffes start life by falling 6 feet to the ground and then getting up and running, right? We are fundamentally different from that. Humans are born, apart from marsupials, Aussie, 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 oi, oi, oi. We are born at one of the most underdeveloped stages in the mammalian kingdom, which means that a baby is actually physically incapable of looking after itself. A baby cannot feed itself, it cannot clean itself, it can barely regulate its own temperature. In fact, it needs a lot of assistance to regulate its own temperature. And we are actually born at a stage where we can't even differentiate between these different adverse experiences. From a baby's perspective, for those first couple of weeks of life, and like any new parent can attest to this, that at first babies cry all the time and you can't work out why. It's just like something bad is happening and I need to be looked after. As to why then we need this attachment, it's because humans need to be looked after. And so attachment can be conceptualized as these adaptive responses to our primary caregiver or our caregiving system in systems which don't have a single primary caregiver, um, and our environment to elicit the care that we need. Um, there are So I hold a view that it is a kind of manipulation, that babies are trying to manipulate you into meeting their needs because they can't do it themselves. They need to be looked after. And so they will respond to the environment and the person who is providing that care in order to keep that care there.
Yeah, it's interesting. So, it sounds like a baby might be a bit insecurely attached, a bit anxious.
Well,
They're not ready exactly to spend time on their own and explore the world. It sounds like they're pretty dependent. Is
ooh,
that
I am going to disagree on that one because part of attachment is this idea that you have even the capacity to do something. Babies can't move their own bloody legs. Of course, they can't go out and explore the world. Like, our early experiences inform our attachment, but you wouldn't really say that, a child that is pre-movement is has any kind of attachment style. You might be able to see some inklings of it, but you can only really start assessing attachment and when they're actually capable of volitional movement and some kind of
separation?
exactly. I'm sure that you're aware of the strange situation test, which is sort of like the foundation of a large part of modern attachment theory developed by Mary Ainsworth. And it is such a fundamental piece of the puzzle to understand how we think of attachment. I
Let's
catch
talk about it. Let's go through it because it'll be really helpful to inform when the next parts of the conversation around different attachment styles.
absolutely.
Yeah,
So this would be this is where it's often more helpful to find a YouTube video that like goes through it because the strange situation test it's this choreographed set of separations and reunions. The way that it looks is it was developed in the 19 what 60s 70s in the UK. So it is usually the mother who, because patriarchy and misogyny exist, but so it's the primary caregiver brings an infant between the ages of 12 and 18 months usually to the center. there will be a room that has been set up as the observation room. So it'll be full of toys and books and like chairs and like, it's a fun space to be in. They try and make it somewhere that's very similar to like a playroom or a daycare room. And it'll either have, some one-way glass or some cameras so that what's going on in there can be observed without Bub feeling observed. The way that the strange situation test starts is that the caregiver and Bub enter the space, they explore it for a bit. We watch how the caregiver and Bub respond to one another and to this new environment. Um, then a stranger, one of the people on the testing team, a stranger enters the room. We see how Mum and Bub react, so how the caregiver and Bub react. Then we have the first separation, which is the caregiver leaves the room, leaving Bub in the room with the stranger.
Mm.
And we see how does
That is a stress.
it is a stress. If you end up watching one of these on YouTube, one of the things that people really notice is that for securely attached kids, they get incredibly distressed. And it can feel actually quite cruel to be doing this. There's this element of, well, why are you putting a child through this? It's important to remember that these sorts of separations and reunions are part of normal life. Every time a parent drops their child off at daycare, that is a separation. Every time a parent leaves the room so that they can go put on a wash in the washing machine, that is a separation. And that is causing this distress. And seeing how the child and the caregiver respond to this distress really informs our understanding of what's going on and can provide us with some tools for helping to change things. Um, so to sort of come back to the strange situation test, we were at the point of the caregiver had left the room with child there with a stranger. We see what happens. Um, we see how the child responds to the stranger in this weird situation.
Mm.
Then the caregiver re-enters the room. We watch that reunion. We watch what happens. How does the child respond? Um, a securely attached child, to use the jargon, should be like as soon as the parent re-enters, they should be crying, they should be running to the parent. They should take a while to settle down, but they should settle down. They should be able to be comforted by their parent, and then after a bit, go back to having fun in the playroom. Uh, while that reunion is happening, the stranger leaves the room. Then the caregiver separates again, leaving the child alone in the room.
Right.
How does the child respond to this new situation, this new very stressful situation? Like, as we said before, like the human child cannot look after itself. The toddler on the savannah on its own would die. And fundamentally, like evolutionarily, kids are aware of this. So this is incredibly stressful for the child. So then the stranger re enters. How does the child respond to this?
Mm.
Do they go to the stranger? Do they shy away from the stranger? What happens? And then the final reunion is the parent re-enters. This whole, and we watch again, how does the child and the parent
Mm.
respond in the situation? Um, this whole choreograph thing takes, half an hour at the most. Like it's not that long. Um, or at least usually it's not that long. It can take a lot longer. And as we go through the attachment styles, we can sort of talk about, well, what can make it take less time, what can make it take more time, and what does that tell us about the bond that exists between the infant and the caregiver in their environment.
Well, I think we should talk about the different kind of attachment styles there, because it's interesting to. Well, I was about to go into nature and nurture and how that drives different temperaments and
Yeah,
reactions, but maybe it's good to start with an understanding of some of the major attachment styles.
I
Um,
actually think that we should talk a little bit about this nature nurture
Oh,
thing. Yeah,
sure. Yeah. Well,
yeah,
what are your thoughts of the contributions? I wouldn't be so rude as to ask, is it nature or nurture? Because I'd
yeah.
probably get
If you were to ask that,
fired.
well, no, if you were to ask a question like that, you'll get the very boring answer of it's both.
That's right.
So that's why it's better to ask, well, how do they interplay? And I would say that the way that they interplay is that there are going to be factors around the infant that affect their attachment. There are going to be factors that belong to the caregiver that influence attachment, and there are going to be factors that influence the environment in which they live that strongly influence attachment. So, to give some easy examples, you mentioned temperament. There's a couple of they're not these are terms that were developed in like I want to say the 70s or the 60s, so they aren't the most PC
Okay.
terms. But it's things like some kids are slow to warm up, or like there's like these technical jargon terms for temperamental styles. But fundamentally, they're just these things that we have a lot of evidence of being inborn, genetically driven um, patterns of how anxious somebody is, how easy it is for them to settle themselves and or be settled by others,
Mm.
um, and that is one ingredient into attachment, into the infant's factors of attachment. But there's also factors like, does the child have an illness? Does the child have epilepsy? Does the child have some other kind of physical illness that's going to affect them? Does the child have a neurodevelopmental difference? Does the child have, a developing autism spectrum disorder? Or any of those factors can really influence have an impact on the infant's factors to attachment. Then there's the caregivers factors. One of the things that we know about attachment is that it is incredibly heritable in the sense that people with a certain attachment style tend to have relationships with other people with the same attachment style and tend to have children who develop that same attachment style. It's something about this way of being in the world is, it influences how we can then, as if it influences my relationships with others, of course it's going to influence my relationship with my child. So there are these, so a caregiver's attachment style has a strong impact on the attachment style bond that develops between the infant and the caregiver, as does things that are completely outside of the caregiver's control. Things like, do they have an illness, whether that's a physical illness, whether that's mental illness, whether that's an addiction. There's so many things that sort of belong to the caregiver that can influence these attachment styles. And then there's the environment. So one of the things that we know is that people in who are oppressed, people who are in situations of immense deprivation, that really does shift your attachment style. One of the things that is central to understanding attachment is the idea of having a secure and safe haven. And if you are living in a war zone, then like the world is not safe. So you're not going to learn anything about having a secure and safe haven, and that's going to have an impact on your attachment. As does growing up without access to money, without access to food, and a lot of these things are environmental factors. So everything influences attachment.
I'm sure we're going to talk about the different styles, but I'm reminded of an important quote I heard where um, a disorganized attachment style is an organized response to a disorganized upbringing,
100%.
right? So it's actually quite adaptive and always makes sense in the end when you dig down deep enough, um,
Absolutely.
and then that can help with a bit of therapeutic nihilism and empathy, which sometimes can happen.
Yeah, and I think that that idea that attachment is always adaptive is actually really important to hold on to. It's something that also plays into some of the I think the approach for dialectical behavioral therapy has sort of one of the axioms is that people are doing the best they can with the tools they have. And similarly, attachment is always an adaptive, learned response to the environment in which the infant finds itself. That environment that includes its own factors, the caregiver factors, and the world around them.
Yeah. So then, Cam, what are the kind of different attachment styles?
Yeah, so we're going to be talking a bit about sort of like the attachment styles as developed by Mary Ainsworth, who developed that strange situation test we talked about. They are, so her research found essentially four patterns. Um, and they sort of belong to two groups. There is the secure attachment, and then, I think it was, oh, which Russian author was it that said all happy families are happy in the same way, whereas unhappy families are unhappy in their own ways?
Oh,
There's
I like
only
that.
there's
I don't
only
know.
there's only one kind of secure attachment, but there are three different insecure attachments, um, and they are called anxious avoidant or just avoidant, anxious ambivalent or just ambivalent, and disorganized. And these four patterns, the secure, the avoidant, ambivalent, and disorganized, are all based on how kids and their caregivers responded to the strange situation test. And so we sort of use the strange situation test to understand them, but then we can also apply those patterns to what that child is learning about themselves, about relationships, and about the world around them.
So there's these different attachment styles that get observed when you're a child, but does that mean that you're seeing them as a child? Does that mean that they're destined to have that attachment style the rest of their life?
Absolutely not. No. So
Oh,
attachment styles are not destiny. There are certain associations with them. So we associate secure attachment styles with there's a lot of evidence that people with a secure attachment style are more likely to have better physical health, better mental health, stronger relationships, that kind of thing, and that people with insecure attachment styles are more likely to have poorer health outcomes and poorer relationship outcomes. However, it's not destiny. Just because I'm securely attached doesn't mean that I can't get schizophrenia. Just because I'm insecurely attached doesn't mean that I can't have an amazing life. And also, we can see people shifting between these attachment styles. And look, my personal philosophy when it comes to therapy is that all therapy is a kind of reparenting, and all of it is essentially trying to shift people from various insecure attachment styles into having a more secure attachment style. And we do see that working.
wow. So why don't we explore what the different attachment styles are? What do you see in someone who's securely attached, and what about in the anxious attachments?
Absolutely. So, a securely attached person going through the strange situation test, what you would see is that they enter this strange place and they're weirded out by it. They're finding it's a new experience. Things that are new and unknown can be quite frightening to young kids, and so you often see them clinging on when they first enter the space. But then with a little bit of time, a little bit of encouragement, they were able to start exploring. They're able to start playing with things, maybe at first only with the parent, but then they might see something across the room that they're really interested in. They'll go and grab it and bring it back.
They'll leave the parent.
Exactly.
Mm.
Um, and then they'll come back to the parent, they'll share in that joy. What you'll see as well is that in those separations, the child will get really distressed. The child will often be crying. Um, they'll show their distress in all the ways that they have. A securely attached child will probably avoid the stranger in the strange situation test. They probably won't seek comfort from the stranger. Um, they won't necessarily completely run away from the stranger because there's a bit of an implicit indication when a parent has left a child alone in a room with somebody that the child is like, well, my parent would not have left me if this person was dangerous, so surely it must be okay. So they won't necessarily completely stay away from the stranger, but they might. Um, and then on reunion, when the parent comes back into the room, the child would go to them. The child will be crying, and it will take some time for them to settle down. And the parent will be able to settle them. The parent will be able to tolerate their distress, will be able to sit with them through that and get them out of it and get them to be playing or reading or whatever it is that they do together. So, what this sort of shows is a that the child sees the parent as being safe, that while they're with that parent that they are safe. It's like this is a strange new place, but I'm holding on to my parent. So I am safe. I'm saying parent, caregiver, could be a grandparent, could be a foster parent, whatever.
Mm.
So it holds on to the caregiver because they are safe in this uncertain world. But then they also demonstrate an ability to be able to go out into that uncertain world to say, oh, there's something out there that I want. I can go and do that. And when I do that, I can be sure that caregiver is still here and they can come back to them. They also learn that when things go bad, so on those separations, and separations are really quite traumatic for young children, during those separations, they learn that uh, I can feel bad, but I can feel good again. And when my caregiver comes back, they can help me feel good again. And importantly, the child also learns by crying and by going to their parent that other people can help me feel better. When I feel this bad, my caregiver is able to get me through this. So, what does that show us about their understanding of themselves, of relationships and the world around them? Because, these are all important key factors
Mm.
in terms of what the child learns about themselves through, or what we can see the child knows about themselves through this. It's that I am capable of going out into the world. I am capable of being helped. I am capable of asking for help, and asking for help works. It shows, their understanding of other people, that other people can help me. Asking for help works. And what it also shows us is that some people are safe, some people I'm not so sure of. What it shows the child understands about the world around them is that the world is a place where good things can happen if I go out into it. It's also a place where bad things can happen, but it's a place where when bad things happen, good things can come after that. I can be made whole again. Um, it's a it's astonishing how much you can read into like these quite simple interactions of just separating and reuniting. But through that, we can see so much, or we can interpret so much about what's going on for that child.
So I guess an important thing to note is a lot of this is unconscious for
Hmm.
the child. They're not wording these thoughts
Yeah.
and stuff.
I've not yet met the 13-month-old who's
Who's got
able to
that
say,
insight?
yeah.
And so when people feel like you know, oh, I can't remember being a kid, so why would anything
Hmm.
like during that phase affect me now? Well, there's a lot of things you can't remember that influence how you develop, of course.
Absolutely.
Yeah, and the other thing to take away is that kids cry. Like it's
Yes.
not abnormal, and I think some parents feel a lot of shame around it or panic as well. And yeah, as you're saying, that is the tool of children. I'm sure parents know this, but
Hmm.
for people who don't have kids, it's and they hear babies cry on a plane or whatever. Maybe this will help
Hmm.
promote some empathy, but that is their tool of expressing their needs. Um,
Absolutely. And it's
yeah,
the only tool they have for
yeah,
quite a
it's
long time.
yeah, and some of us still use it in our adulthood as well,
I know
for
I
better or
do.
worse. Yeah,
I
that's
know I
right.
do. Yeah.
Yeah, so that's been really insightful to hear about that kind of secure attachment response to that experiment. I'm just wondering quickly, does that still pass ethics boards? It's not that unethical, but it's distressing. Do
It
they
is
still do the strange experiment?
absolutely.
Yeah.
So I've not personally been part of it, but there are definitely attachment centers, mostly in larger places, London, New York, that kind of thing, where they will sometimes bring people in to do a strange situation attachment assessment of a particular infant caregiver relationship, and it's not for research purposes; it is for clinical purposes.
Right, of course. Okay. And so, what are the kind of findings you might see in someone who's got one of the anxious? Let's go through the different anxious attachment styles. So, maybe dependent is a good place to start next. So,
Uh,
anxious
so,
dependent style,
anxious dependent is. I'm really glad that actually that you brought that up. So, anxious dependent is part of I think, the adult attachment.
interpretations.
Yeah,
Right.
right. And
Sorry.
so, no, it's no,
It's a good.
it's something important that we actually discuss. Is that I am looking at this from the child developmental perspective, and then applying that to my adult practice,
Right.
which is different to the sort of adult attachment styles that you can come across, which have things like dependent. I actually don't know much about those adult attachment styles. I know I would say that my knowledge of the infant attachment is relatively deep, and that's how I can use it in my practice and how I can apply it. But yeah, I actually don't know that much about the dependent.
Yeah, personalities and
Yeah.
things. What about the avoidant response? Would you?
There we go. I can definitely talk about.
Now we
I
can
can
talk.
talk about avoid until your legs fall off. It's
You're not
all
going to
good.
avoid it?
No, I'm not going to avoid it. Just this once for you. I feel really safe here. That's why I can
Oh,
do
right.
this.
This is good secure attachment.
Exactly. So the avoidant attachment style is the second most common attachment style that we see in the West. So the most common is secure. About two-thirds of kids, or two-thirds of adults too, have a secure attachment style. In the weird cultures, the Western, educated, industrialized, rich, democratic cultures, we see then that the second most common is the avoidant or anxious avoidant attachment style. So, what we see in the strange situation test with the anxious avoidant attachment style is that externally, it will actually be a much more pleasant thing to watch. So, the parent and the kid will come in. Sometimes the parent will be, they'll start exploring the environment together, they'll be playing together. Sometimes the kid will go off on their own, like almost immediately, and start playing on their own, and the parent will sit there and supervise. But it can be something where you see these beautiful interactions between the caregiver and the child, or you can see very minimal interactions. Uh, where this attachment style really shows its strong differentiation from the secure attachment style is in the separations. So, externally, what we can see is that on those separations, the child doesn't look that fussed. So, the child will continue playing on their own. They might look around a bit, but they won't be too bothered by the fact that their caregiver isn't there. And then on reunion, when the parent re enters the room, the child might not go to the parent. The child might actually move away from the caregiver, might stay away from them. Um, and if they go to the caregiver, because sometimes they are so distressed that they can't deal with it on their own, and so they go to the caregiver in a little bit of distress or showing a little bit of distress, they settle down incredibly quickly. They get redirected really quickly. Um, so externally, it looks like this child actually doesn't have anywhere near as much distress as the securely attached child. And look, it was hypothesized early on that that was uh, not a true interpretation, and then proven beyond all doubt when they did some ECG testing, where they just put the ECG recording dots on the kids um, when they were doing these attachment assessments. So, as you can probably anticipate, when you're more distressed, your heart rate goes up. So, securely attached kids, as soon as the parent left the room and they got really upset, their heart rate went up. With these anxious avoidant attached kids, when the caregiver left and they looked completely unfazed, their heart rate skyrocketed. These kids were in intense distress, but were not showing it. And they were settling down when the caregiver came back, but it took a lot longer for them to settle down. And this is, we talked about how this is an adaptive response to something. This is an adaptive response to a parent who is obviously safe, who's obviously able to meet their needs, but who isn't necessarily able to meet their emotional needs. And importantly, where crying and distress does not actually work to communicate that I need help. Um, the sort of situations where we see this happening is in parents who themselves can't handle the distress, like their own distress or the distress of the infant. So, parents where, while the child is crying, they move back, they step away, they separate themselves from the crying child, and very quickly that child will learn, oh no, I can't let you go away. You going away is how I'm, the infant alone on the savannah. That's how I die. Crying is fundamentally it's fundamentally punished by the system. Um, and obviously, no one's doing this consciously. This
Yeah.
is all
And it's
unconscious.
no one's fault.
No, it's
You
nobody's
don't
fault.
choose your attachment style.
Exactly. But it's all about us noticing that, oh, for this relationship system, crying, expressing distress doesn't work. The impact that then has on the developing child is like, well, one, the child is learning, I can be safe. I can go out into the world, I can do things. Um, my caregiver, they're going to be back. And, but when they're back, if I cry, if I ask for help, it's not going to make things better. If anything, one of the beliefs that that people can develop as part of an avoidant attachment style is that asking for help just makes things worse. Um, I'm not sure if you've how do I want to put this? Uh, One of the things that I like to do when talking about attachment styles is try and do broad strokes of what does this look like in terms of people's day-to-day experiences. Um, I would say that male friendships are very avoidantly attached. So, uh, like I said, a lot of the time you'll see these beautiful interactions where the child and the parent are playing together. And that's what you tend to see with male friendships. Male friends will, get together to, play footy or play D&D or like do all these things. They do something together, but they're never vulnerable. They never tell one another what's going on inside because they have learned that that doesn't work, that that does not meet my needs. It also, uh, actually, I don't think there is an also there. It does not meet my needs. Yeah.
Not to put a value judgment on it,
Mhm.
but I think there's a that I've had, yeah, that it's really nice to show some vulnerability with friends, and that, and hopefully that you, if people are wondering about whether they should ask their male friends for help or to express distress, that maybe they'll be surprised, because I think secretly a lot of us do want to kind of access a deeper. Well, I'm not potentially very avoidant. If you're avoidant, maybe you don't want to kind of get there. But I'm just having memories come back of some interactions I've had with friends, and thinking about how, yeah, the nature of the relationship was probably a bit more competitive and avoidant, but actually it was in crises and in distress where you can get to a deeper connection. And it's interesting how crisis and vulnerability can actually augment, improve relationships sometimes. Yeah,
Absolutely.
it's an
It's
interesting reflection.
in a very real sense, it is like relationships can only grow when there's been some kind of a breach in them.
Wow.
It's, we're not like, a house made of stone and wood. Like we are a living system. We all know that when bones break, when they can heal stronger if they're set right. If they're in a healing environment, when they heal, they are stronger. And that's the same with our relationships. The strength of our relationship. If we kept things superficial and avoidant and always happy go lucky, then there's not much depth or strength to that relationship, and that relationship can be put down anytime. It's only when you have breaches in the expectations of that relationship, you know, we're colleagues, but you and I haven't sat down and had like a deep and meaningful about the awful things that have happened to us. But if we were to do that, then that would be a breach in this kind of relationship we have. And through that breach, we would then, I assume we would then heal that relationship. And through that, we'd learn that, oh no, this person is someone I can be safe with
Yeah,
and who I can share that in.
that's right. Yeah. So in a superficial, happy-go-lucky, just play cricket on the
Mm,
weekends kind of relationship, there's a lack of safety in showing vulnerability. But as you show it, depending on the interaction of the two people, you can get a deeper sense of safety, and that's a beautiful thing. Yeah.
absolutely.
So that's anxiously avoidant.
That's
I'm going to
anxiously avoidant.
avoid going any further into that. Um, Pardon all these puns. I'm in a mood. And so, where's the best next attachment style to explore?
I think exploring the anxious ambivalent attachment style.
Yeah,
So,
which
in
I think tends to. I was going to try and link that to dependence, but I won't do that. I think let's just talk about it as its own thing.
my understanding is that it is linked to the dependent one.
Yeah.
And it sounds like you have a bit more understanding about those adult attachment styles. And so, as we're talking through it, I would love to hear the connections that you're making with those, because, in my opinion, it's these sorts of cross-disciplinary, or like these aren't really two distinct disciplines, but it's through making these connections between different areas that we can really broaden and deepen our understanding.
Just on that point, yeah, psychiatry is not just about meds, by the way. We're doing psychiatry training, and we haven't talked about a single medicine in 45 minutes of talking.
Exactly.
So just as a shout out to people who just think we're pill pushers or whatever. Not that we're psychiatrists, we're in
Yeah.
training, just to make that clear. But
Exactly. You and I both signed the same piece of paper that
that's
said, I will not style myself a psychiatrist.
that's right.
I love that. Oh, goodness.
Yet.
Yeah, exactly.
We'll see how we go.
Fingers crossed, one more year for me.
Yeah, that's right. So ambivalence. Ambivalent.
Yeah. Importantly here, ambivalence means something different in the jargonistic term than it does in everyday parlance. So if I were to say to my partner, my partner said, "Oh, do you want to go out for Italian tonight?" And I said, "I'm ambivalent about that." That
Which, by
can't,
the way, why would you be?
yeah, because Thai exists.
Okay.
That is why.
Fair.
And because I'm secretly trying to signal I want Thai. Anyway, so it's this thing of in common parlance, ambivalence means, I don't care either way. In psychiatry and psychology, ambivalence means two strongly held opposing views. So when we are ambivalent about something, it might be because for example, if I'm ambivalent about, moving to Brisbane, I have this strong positive there of, oh my God, I hate every single winter in Canberra. I freeze half to death. And if I move to Brisbane, I will never be cold again. And on the other hand, all of my family are here in Canberra. I have such strong friends and communities here in Canberra, and I would not have that in Brisbane. So I have this strong ambivalence about moving to Brisbane, which is why we use that term for this attachment style, because we see two very different modes of behavior in the ambivalent attachment style, um, but they are united by something. So what we see in the ambivalent attachment style is the caregiver and the child will enter the playroom. They'll be able to play together. It'll look really beautiful. It'll look superficially very similar to the secure attachment style. Um, the what we'll notice maybe is that the child stays quite close to the parent. Like they don't necessarily go out as far to, or it takes longer for them to go out to start playing with things. And so we might get an inkling that there's an ambivalent attachment style going on here while they're still in that first exploratory stage. But it really becomes obvious on the separations. So, no, separations, no, it's the reunions that becomes obvious. So on the first separation, you'll see the child become distressed. A child in distress is a child in distress. We're not going to say it looks more or less distressed than the securely attached child. Definitely more distressed than they look more distressed than the avoidantly attached child, but like they look distressed. On that reunion, this is where we have those two opposing points. So some of the kids will run to the parent and they will be inconsolably crying. They will be crying harder. They'll often be showing more distress than they were before the reunion. Like when they were isolated or with the stranger, whether it was with the stranger or on their own, they will be showing more distress on reunion than they were in that moment of separation. And it will take forever for the caregiver to settle them down. The metaphor that gets used by a lot of parents when there's an ambivalent attachment style between them and their child is that no matter how much love I pour into this child, it's like their cup doesn't have a bottom to it, just pouring right through, and they can never feel better. So what you see is these kids, one of the valencies, one of the two options is that the kid will run to the parent and be inconsolably crying, and almost impossible to settle down. The other valence, the other option, is that the kid on reunion will attack the parent. They will run up to the parent. They'll be angry. They will be kicking. They will be punching. They will be biting. You see this incredible, or if they're vocal, they might start yelling. They might start expressing this really strong anger. So whereas one of the valencies is this sadness, this like, I need you. How could you do this to me? The other
Never leave me
valence,
again.
yeah, the other one is this incredible, like, whether it's verbal or physical violence directed towards the caregiver. This is importantly, the reason they've been lumped together is that they are both responses to the same set of situations. And it's, sometimes you'll have a kid that on one day will have the sad reaction and another day will have the anger reaction. Sometimes you'll have kids that are always in one reaction mode and never in the other.
Is it
Um,
gendered? Do you find that boys who externalize more are more violent, and females and who are maybe a bit more quiet will be more um, expressing distress?
So I would say that there is a strong socialization aspect to it, absolutely. And that then plays into, if we get the opportunity to talk about how these attachment styles then link to personality disorders, that then really plays into a well-known gender-based diagnostic difference in the personality disorders.
Yeah, let's go
Um,
there.
yeah,
But
we'll
we'll
we'll get
finish
there.
up. But
We'll get there.
yeah,
Uh,
be patient, still.
So, and so what could possibly, how could these two things, this, inconsolable sadness and this incredible violence or anger, how could they be addressing the same need? Um, and that's an exercise for the listener. I'm curious, Sil, have you come across this like way of thinking about it before? Do you have an answer ready for what they're responding to?
Well, I guess the way I would think about it, I think I've kind of just learned about it through lectures.
Yeah.
It hasn't been that forefront in my
Mm,
clinical style. I usually tend to think about how people relate to others and themselves and the coping mechanisms that are used,
mm,
and think about the coping. I mean, this would take ages to go through,
yeah.
but I usually try and that's where I'm at the moment in my
Mhm.
development. It's really what coping mechanisms are used, and each coping mechanism, I see it, try and look at it on a spectrum of helpful and unhelpful,
Yeah.
and different states and stresses put people into
Mm.
using it in unhelpful or more helpful ways. So
So it's like you're observing what is the person doing, using some of those um, categories that we're taught about how you can analyze that, and based on this pattern that you're seeing, you can try and infer some things about what might be some helpful things you can do to help shift somebody from using the less helpful to the more helpful coping strategies.
yeah, so I get just an example
Yeah.
that's popping into my mind. If someone usually retreats into fantasy and is withdrawn and avoidant, um, that can be maladaptive and unhelpful, or it can be if they're expressing their creativity, that can be very helpful.
Mm.
And a really wonderful way to explore this is asking them what are their strengths,
Mm.
and depending on why they're presenting to hospital or why I'm seeing them, trying to and that's a very supportive psychotherapy thing, to try and identify people's strengths and use them to try and resolve whatever
Mm.
behavioral issues there. But I guess here what I'm thinking about is there's a coping mechanism of aggression
Mm-hmm.
and externalizing behaviors, and that can be I'll avoid jargon, but that can be transformed into something more helpful in time,
Mm-hmm.
like exercise and sports and bits and bobs. And how to do that, I would consult my my colleagues.
Do not point at me. I'm not yet a psychiatrist. I have not styled myself a psychiatrist this whole time, so.
That's right. But yeah, so that would be how I kind of think about it. So how do they do the same thing? Yeah, I guess they're trying to evoke a caregiver response though, and get some emotional needs met. Oh, I got
Exactly.
there?
Yeah, you
Okay.
got that. That
You just got
was
to ramble
the,
long enough
y-
and the answer will be there somewhere. That's
exactly.
my strategy.
The similarity between these two things is that they are both unignorable, right? If you have somebody who is latched onto you and bawling their eyes out, you can't ignore that. If you have somebody who is punching and kicking you, you can't ignore that. It is meeting the need because what they have, the environment in which they are is one in which their caregiver is able to meet their own emotional needs. They're not like the avoidant kids where they know that crying doesn't work. Their caregiver is able to meet their emotional needs some of the time. So this is something that we see in a response to, like, I'm trying to not to do anything too derogatory here, right? Where sometimes when we talk about these, it can feel like we're really blaming parents, but like everybody's doing the best they can with the tools they have. Uh, but for example, if a parent has, let's go with multiple sclerosis, especially there are kinds of multiple sclerosis where you'll have periods where you're really disabled by your illness and periods where you're not as disabled by your illness. And when you're not as disabled by your illness, you can be an amazing parent who's, playing with the kids and looking after them and interacting with them, and that's amazing. Um, but then when you're having a flare up, you can't do that. You are in pain. You are physically incapable of looking after yourself, let alone other people for some people with multiple sclerosis. And this can then lead to the child learning, oh, no, but you helped me, but
Last
sometimes
Wednesday,
you
you
didn't.
cuddled me.
Yeah, exactly.
Yeah,
You
what's
did
going on?
that. Why aren't you doing that today?
Mm.
I need you. I still need you. What they've kind of learned, and you can also see this in the way that they don't go out and explore the environment when they enter it, is they don't know that if I go out there, that my caregiver will still be here. And even if my caregiver's here, I don't know if they'll be able to look after me, if they'll be paying attention to me. So the ambivalent response is one in which a child has learned that they can't do things on their own. They can be looked after. Other people can help. In fact, it's only other people that can help. And the only way to keep people helping are these is to have this big unignorable response.
So, disorganized attachment.
Hmm. So
What can you tell us about that?
disorganized attachment is different from secure, anxious ambivalent, and anxious avoidant in a very important way. So one of the things that's unified the other three that we've talked about so far is that the parent is fundamentally meeting the child's needs, that the parent is safe, the child knows that good things can happen, whether that's, and I cannot possibly leave my attachment figure in case they're not there again, or whether it's because, and my attachment figure can't really help with that, but I can make good things happen. Those are responses to parents who are, fundamentally safe for their child. The disorganized attachment style is what we see in instances where, you know, there's not that safety. Whether that's because the parent is not safe, the parent is the one harming the child, whether that's because they live in a situation, in an environment that is so overwhelmingly dangerous that the child could not possibly learn safety. Um, if the child doesn't have that secure base, then everything else that we've been using, all the tools that we've been using to look at how these children act in this strange situation, they don't apply. The reason that it's called the disorganized attachment style is because unlike those other kids where like we can actually pretty well predict how they're going to act, like on that first separation reunion, based on that we can say, okay, we're pretty sure we know which way this is going to go, and then those predictions are usually pretty accurate. Kids with a disorganized attachment style, they don't act in the ways that we anticipate.
Unpredictable.
It's unpredictable, it's disorganized. And that's because they don't have that fundamental sense of safety. What you can then see, though, is because as we were talking about, kids need to be looked after, these kids are still trying to elicit care. And that's one of the reasons why it's so important that we have the stranger in the strange situation test. I'm not sure if you've had this experience, but when I was doing my child adolescent term, we had a very young child come in. So he was 6 years old. He'd been brought in due to some essentially significant carer burnout in the context of his violence at home. So, one, we already know there's something weird going on when a 6-year-old child is being violent. Specifically, there was a lot of violence towards family pets. We know something is going wrong in that household when a child is being violent towards animals. And the first time I met this child, so it was in the hospital room. Usually, I'm not sure if you've ever interviewed or like assessed a child that young as part of your medical training. Usually, you walk into the hospital room, the child will be terrified of you and stay away and like hide behind the caregiver. Within 30 seconds of me sitting down in the chair next to the bed, this child was trying to crawl into my lap. This child was desperately seeking an attachment figure, anybody who could meet his needs, because fundamentally didn't have a safe attachment figure. And that's one of the things that we see in the disorganized attachment system. It's not the only thing that we see. You can have it, like people can have a disorganized attachment style and not be seeking other attachment figures because perhaps they have never had a safe attachment figure. And so it is, you know, what they have been taught by the universe is that no, it is not possible for people to be safe. I am alone. the world is a dangerous place. That makes the disorganized attachment style is fundamentally different from the other attachment styles. It's one of the reasons why it is more strongly associated with physical and mental ill health than the other attachment styles. Uh, and it is, importantly, not destiny. You can have a disorganized attachment style and have wonderful, fulfilling relationships, be healthy. You can start off life having a disorganized attachment style and have that change over the course of your life. Um, just because we often talk about these things as if they are these, like, written in stone at the, beg your pardon, like written in stone at a certain point of a child's life, that, from this point on, yea, they shall be miserable. But no, that's not the case. Um, However, it is really important that we acknowledge that no, these are kids who have gotten off to a really rough start in life, and their responses are them desperately trying to adapt to it.
So now we've got a sense of how different children and attachment styles, how different children will respond to stress, to
Mm.
response to caregivers leaving and coming back. How does that map into your clinical practice when you're mostly seeing adults?
That's a great question. For me, it's about understanding then, based on my assessment of, okay, how does this person act in their relationships? Because importantly, these attachment styles, they were developed during the um, like the 50s, 60s, 70s, during the peak of the behaviorist movement. So this is a period of psychological science where we were really responding to and rejecting the internal world stuff that the psychoanalysts had put forward. And so all of this is stuff that we can externally view. And based on our observations of somebody, we can infer certain beliefs. And so that's what I use it for. When I talk to people about, themselves, their relationships, especially with sort of really strong figures in their life, whether that's a partner, whether that's a parent, grandparent, whoever, try and work out what's going on in those relationships, and based on that, try and, roughly put them into one of the buckets. And based on that, I can then infer some of these beliefs, and then I can start questioning, okay, well, what does this person hold beliefs like, you know I can do things by myself, or I can't do things by myself? Does this person hold beliefs that, this my attachment figures are, if they leave, they might never come back? And through that understanding, that can then shape me into working, well, how can I help this person move from these patterns of behavior, which, as we've said many times, were adaptive. They were learned because of that early environment, but they are no longer in that environment. How do we help them shift to a pattern of behavior that is adaptive for their current environment, or that, is sort of more, inverted commas, objectively adaptive, and that can help shift their environment to one which is, more strongly associated with health and well-being.
That's a great question. How? How do you do that? Just in a quick
Yeah.
1 minute, do you mind just
Oh,
uh,
absolutely. Like, because,
obviously it's super challenging, and I'm just
mm,
my mind's going to repetition compulsion, which is this
mm,
concept um, around how people who've had traumatic upbringings find themselves in traumatic situations,
yes.
and it's also a concept of the experience of post traumatic stress where disorder, where your brain, without you choosing, will trigger flashbacks and bring you back to extremely traumatic environments, and
Mm,
it's a compulsion. You don't choose it; it just happens, and it can be and that's and the repetition part of it is just the fact that it is unrelenting and horrific,
mm.
and so I'm imagining someone in who started off with a disorganized attachment style with troubles in their early attachments. How do you help someone like that, uh, in a way, reintegrate healthily, if for lack of a better word?
Yeah. So this was actually part of the framing that I used in consultation with my supervisor for my long-term psychotherapy case. where you, based on your assessment of somebody's, or based on my assessment of my person's attachment style, I then worked out with my supervisor, okay, so what behaviors do I need to model and what behaviors do I need to encourage in this person in order to help move them towards that more secure attachment style? So to take the example of a disorganized attachment style, the thing that we fundamentally need to help them with is the belief that it is possible to have a safe and predictable attachment figure.
And consistent.
Exactly, because
Mm.
they've not had that. So this is where it becomes really important to uh, so, for example, if I was providing psychotherapy for a person with a disorganized attachment style, I would say, you know, I have an appointment slot for them every single week, and I would have to be never late, never change the room, have a really predictable run of the session. So, for example, every time they come in, the first thing we talk about is, or we always set an agenda and we always follow that agenda. We always finish the session at the time we finish. We always start the session at the time we start. And through this, and importantly, I am always safe for them. I don't try to hurt them. I don't, you know, a lot of the rules in our profession, if anybody has ever looked at the uh, RANZCP's ethics statements and that kind of thing, there's a lot of stuff in there that is, it's a rule that's been put in there for a reason. Uh, I do not have sex with my patient. I do not actively seek to harm my patient. There was a
You
case.
hold a very firm frame.
Exactly. You
Yeah,
hold a
and
firm
don't and
frame.
try not to breach it. And as a tangent, I'd be interested in knowing how you end your sessions on time all the time, because that can be very challenging for a lot of
Mm.
early career therapists and doctors, ending on time when there's one more crisis.
Oh, oh gosh, yeah. To bring back to like patterns that we see in people, the classic pattern that you will see in patients who have an avoidant attachment style is that in the last 5 minutes of the session, that is when they will bring up the big issue.
Yeah,
It's like, everything's been going fine. You've had a great chat. You've really maybe done a bit of CBT stuff in there. It's been great. You've set the homework. Cool. We're
feeling
just
good. You're
wrapping. Yeah,
feeling like it's wrapping
exactly.
up.
And yeah, I self-harmed for the first time last night, or for the first time in 2 years last night. It's like,
Yeah.
wow, okay.
What do they call that? The doorway issue, as they're going
Yeah,
through the doorway.
exactly.
It's the kind of throwaway comment that has all the
Hmm.
value. Oh, we can't talk about it. I got to go.
Exactly. And that's because they have this idea, this belief that sharing that vulnerability
Mm.
isn't safe, won't work. And if they mention it earlier in the session, you'll have to talk about it, you'll have to confront it, and that will be bad. And a lot of people in avoidant attachment style have this belief that my distress hurts other people, and so I can't share that with anybody else. But they also know that, like, I'm here to talk about this stuff. So it's often what you can notice is from the therapist side is this whole time there's like, oh, the session isn't quite feeling normal. Like there's this like undercurrent of tension, but like everything's running okay. And then it's like this big release of tension when they actually bring up the thing they've been wanting to talk about this whole time, but their beliefs, their desire to share, their desire to be vulnerable is in direct opposition to their deeply held belief that I cannot be vulnerable. Uh, and then they resolve that tension by mentioning the thing when it's too late to share it. Bam, out the door. It's like, well, bugger.
Mm. That's a beautiful example of how important countertransference monitoring
Mm,
is. That feeling that something's just not right here,
absolutely.
and then boom, there's the comment, and oh well, we've got to end. So that's insightful.
Yeah. And we were talking about that because it was like, oh, the strong frame. How do you finish on time? That is a skill that I am slowly developing. I am a
Nice
classic.
to know I'm not the only
Yeah.
one. Yeah.
Oh God, yeah. It is so important to. It's one of the reasons why these days every time I see a patient, even if it's somebody that I've seen, dozens of times, I will set an agenda. I will, in the first couple of minutes of the session, say, cool, these are things I want to talk about, catch up. how the meds go and make some plans. What do you want to talk about? Oh, you want to talk about a medical certificate. Brilliant. So we will do these four things. And then I've got a rough idea of what it is that we're going to talk about. And that's what we talk about. Uh, of course, you do have to be adaptive. If something comes up during, the catch up over the last couple of weeks that deserves time, you do have to be able to give it that time. But yeah, it is just all about, for me at least, having an agenda and trying to stick to it and making sure that there is a clock on the wall above and behind your patient so that you can every so often looking at your watch, awful, terrible. Eyes drifting up to the ceiling, that's fine.
Acceptable.
Yeah.
I think I agree strongly with that and the value of agenda and of an agenda when you're running a clinic and you need a whole
Mm.
time, of course. Um, CL psychiatry, where you don't necessarily have like booked patients, you just have
Mm.
people you need to see. I've found it more helpful to for initial assessments to not have an agenda, to just let um, the patient, if they're not too avoidant,
Mm.
flow through everything they've wanted to say and haven't had a chance to say. And usually, one of the things I've been trying and have failed about 100% of the time is to just ask one question and then be quiet for 10 minutes. But I can't handle
The
the
cla-
awkward stares like, say something. So
so
usually I can sometimes get to 5 minutes though, and that's pretty good for me who talks
mate,
too much. I mean, I have a YouTube channel. So,
oh my
but
god, that's
really,
true
just a
insight,
lot of
mate.
silence is something the people I'm seeing haven't really had an opportunity to have and explore, especially with doctors.
Yeah.
Yeah. There was an interesting study I heard about, and I've only heard about it in conversation, so feel free to prove me wrong. But it feels right based on my clinical experience. It was an ED study, and doctors would either stand or sit for 3 minutes, always 3 minutes. They had a
Hmm.
little buzzer or timer in their pocket, and then patients were asked, how long did the doctor spend with you? And if so, patients would say 1 minute if the doctor stood, and would say about 5 to 10 minutes if the doctor sat.
Mm.
Don't know why my brain went there, but that is a strong argument to just always sit.
Absolutely. Yeah. No,
Eye
no,
line.
yeah, it's the eye line, it's the change in the power dynamic.
Mm,
Because one of the things that I think it's really wonderful that you try and be as free flowing as you can and as responsive as you can in your interviews. One of the things that I would encourage is, there is information we need to get, and it can sometimes feel really arbitrary to the patient. Like, you've been talking about, for example, what you they're going through right now, but as part of a full psychiatric assessment, you do need to understand stuff about, their, what was their earliest childhood like, what was the pregnancy, that that they were part of, like what was their earliest experiences at school, like you need to know about the drug use, everything. A comprehensive psychiatric assessment is very invasive. And if you don't know what goes into it, it can also be really bizarre. And like, where are these questions coming from?
mm.
So that's one of the reasons why I can sometimes find it, well, I have found it really helpful to provide just a little bit of scaffolding.
Right, and signposting.
Exactly.
That's I think that's very true as well.
Yeah.
You don't want to go from talking about you know how someone fractured their knee and then going straight
Mm.
into
Yeah.
childhood,
Yeah. And
whatever.
tell me in only positive words everything you can about your mother.
Yeah,
Love that stuff.
only positive words. Wow. So a big part of every psychiatry registrar's clinical life is working with people who have, uh, severe mental illnesses like schizophrenia, but also have comorbidity or just what we call personality disorders. And it's tricky. There's lots of different personality disorders, and they influence how people attach and relate to others. And I was wondering if you could help kind of link what we've talked about in attachment to some of the things we see in different personality disorders. Maybe we can run through the different disorders to start with.
Yep, I think that's a really good idea. And I think it's one of the reasons why I think the attachment framework is so important to talk about in relation to personality disorders is because if you don't look at things through one of these sorts of lenses, personality disorders can seem really arbitrary. It can seem like just a bizarre list of unrelated symptoms. Like why are these the symptoms of borderline personality disorder? Why is you can like, I think there was a study showing that it's possible for two people to have borderline personality disorder and have no symptoms in common, right? This why is this the same entity? And
Which, by the way, is why I find it more helpful to think about coping mechanisms
mm,
rather than labeling a personality disorder, because
absolutely.
yeah, it ends up actually being more about, well, that's, as you said, it's actually super non-descriptive
Mm,
and usually gives us a bit of a prejudice and bias as to what to expect, which might not always be fair
yeah,
to the patient. So, yeah, sorry, please go on.
absolutely. So it's in a sense it's super non-descriptive. However, they are real and distinct clinical entities. And I think that relating them to attachment can help them to feel less arbitrary and less bizarre and out of left field. So you and I are both being educated within a system that is largely based on the DSM, not the ICD. What are we up to? 11. And as much as there's a movement in the DSM towards a factor model of personality, I think they're going with a six-factor model that they've developed on their own rather than the big five that is used in personality psychology. Uh, at the moment, we use these clinical entities, and so in the DSM, they're split into sort of three clusters. Um, so cluster A, personality disorders, which let's
I think I've got
yeah,
them. Let's bring them up just so we don't say anything factually incorrect. I
yeah.
think it's schizoid, schizotypal, and avoidant is my guess. But we'll bring them up just to make sure we're not saying anything.
Yeah. So you've mentioned schizoid, schizotypal. The other one is paranoid.
Paranoid.
Yeah,
So avoidant is not in a cluster A. Whoops.
correct.
I did have that memorized before my exams, just
Good on
but
you.
it slipped there.
Yeah, look, as with most forms of rote memorization, it was
That's right.
there for the day.
Well, it's just not, it doesn't come into your mind when you're reviewing a patient. Is this a cluster A or cluster C? Like, those are
Hmm.
letters. It doesn't
Look,
help.
yeah, exactly.
But knowing if someone is
Mm,
schizotypal in their thinking or paranoid in their personality, that is quite helpful. So
absolutely.
and then cluster B, then
Mm,
we've got BPD,
mm-hmm.
borderline personality disorder,
Yep,
narcissistic personality disorder,
indeed.
antisocial personality disorder,
Yep.
and histrionic
That's the
personality
one.
disorder.
That's the one we always forget.
Mm,
It's interesting.
feels gendered.
It feels very gendered. There's this, but histrionic girls you represent. There's this really bizarre phenomenon that I've noticed within psychiatry is that there are some of these diagnoses that we feel very comfortable making. We feel
Yeah.
very comfortable making the diagnosis of borderline personality disorder. We feel very uncomfortable diagnosing narcissistic or histrionic personality disorders.
And
And
antisocial. Oh, okay. No, good point.
I
That's more.
think
We're probably more comfortable with antisocial.
especially because we often use antisocial personality disorder in contexts where we are trying to understand some
Yeah.
behaviors that we don't necessarily want to take ownership of in within the mental health lens. So it's this really interesting thing though, where like, you know, yes, borderline personality disorder, people with borderline personality disorder experience enormous stigma within the healthcare system, but there's I would argue, a much greater stigma within the healthcare system against other cluster B personality disorders.
Wow, that's an interesting
But
point.
regardless, then the cluster C.
Oh, up to me again.
Yep, count.
So
I've got to.
avoidant dependent.
Yep, yep. And it's the one that's uh,
Yeah, what's a hint? Give me a hint.
there is a very different disorder that people label this behavior as. I'll give you the first letter O.
Oh, yes. Okay, sorry. I do know about obsessive compulsive personality disorder, egosyntonic. Yeah.
There we go. So so let's start with the cluster A ones
Hmm.
because, to be honest, those are the ones that we see the least often, but they're kind of interesting. Um, so paranoid personality disorder, we often don't talk about it, but according to hopkinsmedicine.org, which I choose to trust in this instance. Uh, it's a personality disorder in which people have a very mistrusting of others. They're constantly looking out for how they're being judged, how they're being uh, abused, how they're being misused. Um, they often see themselves as the target of other people's anger. And there's this fundamental idea that they are in danger, which maps on really well with the disorganized attachment style. These are people who have an experience that the world is harmful and is going to get them, and then that translates to these beliefs that other people are talking behind my back, other people are trying to hurt me, and that's where we create this clinical entity of paranoid personality disorder. The schizotypal personality disorder, which we sometimes refer to as being similar to schizophrenia, but like schizophrenia light. So these are people who can have
I
quite,
haven't heard of that schizophrenia light. Wow.
yeah, it's
Okay.
people with schizotypal personality disorder will have sort of beliefs that are a bit bizarre, very idiosyncratic. They might have some uh, like perceptual experiences that are not quite normal, but don't quite meet the definition of a hallucination.
It's mystical, it's fantastical, it's high, very deeply spiritual.
Yeah,
What does idiosyncratic mean? Sorry.
idiosyncratic is very individual. So if I have an idiosyncratic belief, it's a belief that only I have,
Oh, okay.
that other people, even that I've shared environments with, don't hold.
Oh,
So
okay.
yeah,
Yeah, it's quite a contained within yourself.
yeah,
Like
exactly.
it's not like Catholicism or
Hmm.
a major religion. It would be like your own little
Oh my God.
spirituality or something.
And some other time we can have a chat about the intersection between religion, spirituality, and psychiatry, because that's a personal area of interest of mine. But yeah,
Next podcast. That I find that interesting as well. Yeah,
yeah.
that you're right. So that's the schizotypal
Hmm.
personality who, and I guess the mechanisms that they're using to manage stress is really is kind of using fantasy and ways of explaining, like, not that there's any, and the key thing is there's no, it's not right or wrong to have these beliefs or not.
Hmm.
It's about if they're adaptive or maladaptive. So you're
Absolutely.
absolutely, people can absolutely believe in crystals and their
Hmm.
powers, and that's completely fine
Hmm.
if it crosses a threshold where that where you, holding a crystal cures your cancer, and so you're avoiding medical treatment, well, then that might be going into a dangerous area.
Exactly. Look, we're not here to talk about personality disorders in and of themselves today. If we were, then we would always be talking about criterion zero, which is this interfering with somebody's ability to live their life, to have relationships, to be happy? If it's not doing that, then it doesn't meet criterion zero and they're fine.
Yeah.
Yeah. So, schizotypal personality disorder, uh, people with this disorder, they live in a world that is fundamentally different from that of other people's. Their version of reality is very different from the version of reality that the rest of us share, and that's a whole other discussion, by the way. But it's that difference that I think is really telling, because even though you might not necessarily see the disorganization in their relationships, it's showing that their fundamental belief is so different from other people's because they don't have that shared fundamental belief in safety and security. It's that lack of uh, that shared understanding that then allows their model of reality to drift and be very different from that of other people's. Hence, disorganized attachment style is most strongly correlated with the schizotypal personality disorder.
Wow. I would have thought it was avoidant,
Mm.
but maybe that's more schizoid, and we'll get to
Yeah.
that. Yeah, but that makes sense that it's disorganized. Yeah. Oh, interesting.
And you then brought up schizoid personality disorder, the final of the three cluster A's. It would be great if this was also disorganized attachment, but sadly, the entities within the clusters are great clinical entities. I don't think the clusters necessarily have the same strength to them.
Mm. I see.
So, uh, this is one of those frustrating times where although the root word schizo, which is used in schizophrenia, schizotypal, and schizoid, is the same Greek word meaning like a split. Uh, in schizotypal, that means they are using schizo to refer to schizophrenia, so it's like schizophrenia. Whereas in schizoid, it is referring to a split from other people. So a schizoid personality disorder is, or somebody with schizoid personality disorder is somebody who holds himself apart from others, has no interest in relationships with others. Uh, Sometimes we can almost map it onto, like, we can try and look at it as like, oh, they've got a lot of the negative symptoms of schizophrenia. But realistically, it is just like they have no interest in relationships with others, and they're okay with that.
Mm.
Um, and this is where the avoidant attachment style comes in,
Right.
because these are people who have fundamentally learned that other people can't help. Like, it's not helpful for me to have these
To
relationships,
depend on
to
others.
depend on others. They will let you down every time. That's often one of the beliefs that are held by people with schizoid personality disorder. And as I'm going to say, I'm a broken record on this. Uh, that is a belief that has come from experience. They have learned that because people have let them down in the past, whether they are consciously aware of it or not. We can infer a lot about their life through the beliefs that they hold at the time of review.
Right.
So that's the cluster A's. We've got paranoid and schizotypal personality disorders being linked with disorganized attachment, and schizoid personality disorder being linked with avoidant attachment.
Mm-hmm.
Then we've got our cluster B's. Uh, so borderline personality disorder and antisocial personality disorder have been linked for a long time. One of the things that we mentioned earlier was, when you asked about this gender difference in externalizing versus internalizing behaviors, um, there was a fantastic study that was done on psychiatrists, I want to say in the 80s, I could be wrong here, where they had little vignettes, little, like, single paragraph patient summaries of,
Mm-hmm.
like, let's
A
say,
70-year-old comes in after a big fight, blah, blah,
exactly,
blah,
and just
blah. Right.
describes, some basic factors of them, and, what is the most appropriate diagnosis for this patient. And what they found was that if they had the same vignette but used masculine pronouns for one of these particular vignettes, and if they used masculine pronouns, the psychiatrist, he, him, that kind of thing, the psychiatrist would usually diagnose antisocial personality disorder. The exact same vignette
Oh,
using
wow.
feminine pronouns, she, her, would be diagnosed with borderline personality disorder.
Yep.
So there is a sexist lens that is being applied by psychiatrists to these disorders. I also would argue that there is a socialized gender uh, impact on the expression of them. So you mentioned before that, there is a lot of evidence that women tend to be more internalizing, men tend to be more externalizing. And for those who haven't come across those terms, it's sort of like internalizing is having sort of anxious beliefs, self harm, things of like, I am a. Mm,
Directing negative energy inwards.
yeah, that's
Yeah.
probably
Like, I'm upset. Am I going to scream and attack outwardly
Mhm,
and occupy space,
mhm.
which I'm doing right now,
Yep,
very masculine? Or am I going to withdraw and say what's wrong with me and look within and attack and feel anxious and feel the tension in my body and internalize that energy?
that's a
That's
really
how I
great way
would
to
think
sum it
about it.
up. Yeah.
Yeah.
And it seems pretty clear, looking at this confusion that's held by psychiatrists, that antisocial personality disorder and borderline personality disorder are very similar. One might argue that they are, in fact, two valencies of an ambivalent attachment style. So,
Whoa, nice. That's
yeah,
a nice insight.
there we go. Sometimes I'm not just a pretty face. It's this idea that uh, people with uh, borderline personality disorder and antisocial personality disorder, they've tended to come to these behaviors and beliefs as a result of that inconsistent care. That's one of the reasons, we talked about how people with an ambivalent attachment style, they do seek out their caregiver. They still want that help. But every time it's a crisis, that's one of the things that then drives the help-seeking behavior that we see in people with borderline personality disorder and antisocial personality disorder. They are people who come to emergency departments requesting help. They see doctors, they see psychologists, and it's one of the things that then drives some of the stigma held by medical professionals against people with these disorders, which is that it feels like no matter what I do to help this person, nothing works. I talked
The
before about,
bucket, yeah, the
yeah,
cup with a hole in it. Can't
exactly.
fill it.
And when, if somebody has chosen to become a healthcare professional, uh, usually at least partially they get some satisfaction out of helping people, and which means that they get immense dissatisfaction out of not being able to help somebody. This is also, so that's when there's a lot of internalizing behaviors. That's one of the things that really drives that dissatisfaction. And then when there's the externalizing behaviors, what can then drive some of that dissatisfaction and some of that stigma is, you know, I don't know about you, Sil, but I have personally been assaulted by patients in the context of them having a personality disorder. We have colleagues who have been assaulted by patients, and it is something which is, uh, it demonstrates that that person was in immense distress. Like in my instance, it was a patient that I had seen before and had had positive interactions with before, but on that particular day, that particular time, that particular situation they were in was one in which they could not handle how they were feeling in any other way but to externalize. And it was honestly very helpful for me to consider it on this view that it wasn't that they were attacking me, like, why are they attacking me? I'm trying to help them. It's like, well, this is the only way they have to feel that they can get help and have that help stay. It doesn't make it okay. It doesn't make it, you know, it doesn't change the fact that it was a really difficult experience for me, but I was definitely able to move through it better by framing it in this way, in a much more compassionate way than just like, oh, they're a bad person who hits people, because that's not a helpful way to think about anybody.
Wow. Thanks for sharing that, Cam. And I think that's really useful for any healthcare professional who's been in these instances. The other thing is that when someone is seeing you, they're usually at their worst.
Absolutely.
They've tried their adaptive, helpful
Mm,
strategies. That hasn't worked, and now they're in hospital. Sometimes because the police have brought them in, or someone else has said that it's
mm,
time, and they're feeling yeah. So I'm fortunate enough to have never been assaulted yet.
mm.
Plenty of close calls, and but yeah, it's one of the reasons that usually in 90% of my reviews, the first question is, "How are you doing at the moment?"
Mm.
Uh, and because when I was more junior, I would start off by saying, "So this is what I understand so far," and then I would speak for a minute, not knowing at all what the person is thinking, and them definitely thinking, "Look at this bloody doctor who thinks he knows everything that I've gone through. He's got no idea,"
Mm.
and what a so that yeah. So it's interesting how and by the way, that did generate a conflict, and this person
Mm.
did get upset. So it's interesting how these really difficult situations do change our practice. And
Absolutely,
that's
yeah.
a thank you for sharing that insight around understanding coping mechanisms and stress helps you empathize. Uh,
Mm.
but absolutely does not change whether you call police or whether someone is liable or not,
Exactly.
and the consequences. So I guess yeah. So BPD and antisocial personality disorder, two valencies of ambivalence,
Mhm.
narcissism and histrionic. I shouldn't say narcissism. I should be specific.
Mm.
Narcissistic personality disorder and histrionic personality disorder. What do
Yeah.
you make of those?
So histrionic, I find very easy to map onto the ambivalent attachment style as well. Histrionic personality disorder is sort of expressed usually in people who are very flamboyant, who there's a sense of theatricality to them. It all often feels,
That's a great word.
yeah,
Theatricality.
it's like it's the root of the term is like, I think histrionic is the same root as the word actor, right? And it is this sense that when you're seeing them that like, oh, it feels like they're performing
Mm.
emotions at me. It often feels like there's no substance behind what they're saying or what they're expressing.
Right.
And essentially, that is based in this belief that the only way to get care is to be going through a crisis. It's to have these big emotions, and so it. However, I think it. Whereas in borderline and antisocial personality disorders, often there is this sense of how to put it. There's often a sense of authenticity to the distress.
Hmm.
Like you're seeing somebody and they have no way of dealing with what they're feeling other than to express exactly what they're feeling in this moment. Uh, People with histrionic personality disorder, the same is true. However, the sense you get is that they aren't actually feeling the emotion. And so there's a disconnection between the conscious expression and the internal state. So, one of the things that makes me a
That's
bad attachment theorist is that I personally believe that, you know, as much as these are rough, sorry, as much as these are categories, they are rough categories with fuzzy borders where somebody can be, have characteristics of one but not the other. And like it sort of tells you a bit that maybe their primary caregiver was predictable in some ways but unpredictable in others, that kind of thing. And so I would say that histrionic personality disorder is one where somebody has some avoidant characteristics, where they have learnt to distance themselves from their internal experiences, but has some ambivalent characteristics, where they know that to keep people close, they need to be bigger and larger than life. They can't be an authentic version of themselves.
that's bringing up this what we were talking about at the very start around how attachment's not just about relating to others but the self.
Absolutely.
And I wonder, can you have an avoidant attachment with the self but an ambivalent attachment with others? And that's what this is kind of sounding like.
Mm.
That's really connecting with your authentic self and emotions is hasn't been safe,
Mm.
and being vulnerable authentically hasn't been
Mm.
safe. And so one has to put this unconsciously, this demonstration, and act out what they feel they're meant to look like or act out. Yeah, yeah, I haven't kind of
Mm.
pondered
I haven't,
histrionic personality disorder much, but that is really interesting.
that's a really insightful way to think about it. I haven't thought about it in those terms of the sort of different parts of the attachment having different styles, but I think that is quite a useful way to think about things. And fundamentally, I'm all about how can we use these theories to better our understanding of ourselves and of our patients and to inform our care. I don't have any particular attachment
Uh,
a
True.
to like theoretical purity or the academic side of things.
Yeah.
Then narcissistic personality disorder
Mm.
is probably one that I struggle a little bit more to attach to these attachment styles, but probably closest to an avoidant attachment style. What we often see with narcissistic personality disorder, and I've only treated a couple of patients where I would say that they meet the criteria for that illness, is that it's often driven by a strong sense of shame that there is something fundamentally deeply wrong with them. And so, around this fundamental belief, they construct this thin shell of being very different to that. So, one particular case that I can think of was a patient where, look, they were a daily cannabis user. But one thing that they were very clear with when they saw me was, but I'm not a junkie. I'm not one of those people who, just does drugs all the time and doesn't do anything else. I'm not a junkie. And there's that thing where, you know, the lady doth protest too much, methinks. Like when somebody is saying these things which puts them above others and better than those disgusting dogs who do drugs all the time, there's probably actually the the disgusting dog who does drugs all the time might be a belief they hold about themselves. And so it's a distancing from uncomfortable thoughts, but a very superficial one. Um, the only way that people with a narcissistic personality disorder are able to maintain a sense of positive regard for themselves is to really distance themselves as much as they consciously can from their actual beliefs. So I think it is it is related to the avoidant attachment style. But I'll be perfectly honest, it is one which I do struggle to use this framework to understand. But it's also one which I think people do tend to intuitively get a lot more. People seem to get narcissistic personality disorder in a way that they don't get the other personality disorders. So maybe it's less important to be able to use this framework for it.
It's interesting when we talk about a lot of, attachment styles and defense mechanisms, coping mechanisms that actually occur pre-language,
Mm,
and we're trying to find words to describe it.
absolutely.
Someone saying, those junky dogs,
Mm,
um, and it being said a couple too many times for it to
mhm,
feel natural. Yeah, it feels like that's a projective defense, and that there's
absolutely.
probably a deep-seated fear that, that might be something in their mind, that they might be
Mm,
a junkie, and that it can be a safe, and that might be a really useful therapeutic thing to one day explore, is that it's safe to explore how you see yourself with me.
absolutely. Yeah.
Mm. Well, that's cluster B.
That's cluster B. And
Yeah.
last but not least, our cluster C's. Uh,
So there's avoidant, dependent, and OCPD.
mhm.
Why don't we start with OCPD? Because these are people who are extremely, it's the word fastidious,
Yep.
and they really need all their books in the perfect order, and
Mhm.
that drawer is perfectly organized, and it generates a significant amount of distress when things are not running as they should,
Yeah.
which it's pretty common to hear healthcare professionals being like, oh, that's just, I'm a bit OCPD.
Mhm.
But criterion zero, it's about how it's affecting relationships. Are you breaking up with your partner because, the socks were left out
Mm,
in the wrong place?
mm.
Sorry, excuse the extreme examples, but um, yeah. And so how would that map to different attachment styles?
I think that what I would there's a very telling, I forget which of the lettered or numbered criteria it is in OCPD, in the DSM, which states that it's a person who has very high standards for themselves and others, and who really struggles to delegate. Somebody who cannot allow or trust other people to do things because other people do things wrong. If I ask somebody else to do something, it won't work. It's not going to help. Fundamentally, this is based on an avoidant attachment view of the world, one in which I'm the only one who can be relied upon. Nobody else is reliable. I've got the only way I can have control over an environment in which I feel distress is by controlling it down to the last, atom in my environment. And that's where this, obsessive compulsive personality frame can come from.
Wow. And then there's anxious personality. Oh, sorry, there's avoidant personality disorder.
Yeah.
I'm really hoping it's avoidant
I am
attachment style.
almost certain. I am
Just
almost certain that the avoidant personality disorder. So, people with this disorder are very sensitive to rejection. They avoid situations with any possible conflict. This reaction is fear driven. Uh, they become disturbed by their own social isolation, withdrawal, and inability to form close interpersonal relationships. Yeah, it's pretty avoidant. Like, it's unlike the schizoid personality disorder, where somebody has separated themselves from others but seems to be okay with that. They seem to be happy with that. Somebody with an avoidant personality disorder uh, is aware that they don't like being this way. And that's a
they
really
want connection, but it's too painful.
exactly.
Mm.
There's this fear driven belief that vulnerability and connection will hurt me or hurt somebody else. So they keep on ending these relationships and they keep on skating off any kind of depth to the relationship.
So that's the avoidant personality, and then I think we're up to the last one, dependent personality disorder. Which, if I'm going to guess first,
Mhm.
and you can correct, but I think that would map mostly towards an ambivalent style where um, it's you're going to use whatever tools you've got to maintain the relationship, and that can be dangerous. If the relationship is dangerous, it's something we've seen
Absolutely.
unfortunately in a lot of unhealthy relationships.
Mm.
But is that right? Is that where you would map it? Yeah.
Definitely. And it's, part of that ambivalent attachment style that we talked about was in that strange situation test, they're not able to go out on their own to explore the space without the caregiver. Beg your pardon. One of the features of dependent personality disorder is an inability to make decisions, even quite trivial decisions on your own. A belief that, no, I'm actually not good enough to do this on my own. I can't do it on my own. I
What do
need,
they think? I need their opinion.
exactly.
What I'm going to do is wrong.
Yeah,
Let's get someone else on this.
exactly.
Wow. Oh, that was very satisfying.
Look, I certainly, I feel like I also learned a lot in going through it with you. It's one of the wonderful things about peer-to-peer discussions is that we all have different backgrounds and different ways of looking at things. Like there are probably times that you can tell on that it felt a little bit rehearsed because I really love sharing attachment theory with a lot of the medical students who come on placement in order to help them understand personality disorders and remember them for the exam that they will have to take. And then they can forget about it, don't care afterwards. But uh,
But what they'll never forget is the insights they got into themselves when they heard that for the first time.
yeah.
Because, everyone who
Oh,
works in mental health is
mm,
slightly
mhm.
looking into themselves when they're looking into others.
Oh gosh, absolutely. But yeah, I really appreciated, some of the things that you asked or the connections that you made were ones that I'd never considered. So I really appreciated that.
That's awesome. Thank you so much, Cam. And I look forward to our next chat around, I think we are going to cover religion and
Mm,
spirituality and
yeah,
how that interplays into psychiatry. So that's
exactly.
going to be an awesome chat as well. Thank you.
Looking forward to it.